So if I were going to take a poll, I've got all these experts here, I've got people watching, I get asked this question a lot of time, what's your regimen of choice? And everybody talks about a fluoropyrimidine and a platinum, but in your practice, what's your approach and what do you give your average patient with metastatic gastric cancer, HER2-negative first line? Go ahead.
So usually we use S1 plus oxaliplatin with or without trastuzumab. So maybe this is 80% patient. Additional 20% patient received 5-FU and oxaliplatin because of dysphagia or some symptom. And a little bit, very few patients received the monotherapy because of a poor performance status in first line.
Very good. Manish?
That's great. So I would say about 75% of the time I do use FOLFOX. It's a 2-drug, very active regimen. I think probably 5 to 10% I use single agent 5-FU. And maybe about 10 or 15% of the time I do use a 3-drug regimen because you know, of the features that David mentioned, you know, a young patient who you know, needs symptomatic relief, wants to be aggressive, those sorts of things. One thing to consider, and we'll talk about this moving on, is that a lot of the studies that compared 3 drugs to 2 drugs were in an era where we didn't have that many options. In our careers, we've gone from basically first-line treatment to first and second-line treatment to first, second, third-line treatment, and even fourth-line. And so with the more lines of treatment, you know, it's not clear that patients will be well enough to receive that many lines of treatment. So that may be another consideration to, you know, I do think that, you know, in colon cancer, there's clear data that the more drugs you use, overall, the longer the survival. And I think that may be the case as well. The issue is just getting it there safely.
Now, when you give your FOLFOX in the metastatic setting to patients with gastric cancer, do you include the bolus 5-FU?
Yes, I do. I do. With the FOLFIRINOX regimen, I don't use the bolus 5-FU, like our 3-drug regimen, but for a 2-drug regimen, I do.
Do you ever use FOLFIRI up front?
Very rarely.
How about you, David?
Yeah, I think, again, there's a consensus. I think FOLFOX would be the initial upfront treatment. Some patients we would consider capecitabine, oxaliplatin if they're really opposed to getting central access. I differ a little bit with the hair loss with irinotecan. I think FOLFIRI is a viable upfront option. Patients with neuropathy, patients that have gotten prior adjuvant oxaliplatin, I think FOLFIRI is a viable first-line regimen. And then HER2 patients would get trastuzumab on the every 2-week schedule.
Can I ask you a little bit about if you did use capecitabine? Another question that comes up a lot. We have 3-week CAPOX regimens. We have 2-week CAPOX regimens. We have ways to dose we have ways to dose the capecitabine continuously. We have ways to dose it on and off. What are we to do?
Yeah, I dose it 1 week on, 1 week off. My experience is that when patients get 2-week schedules, they have a much higher risk of hand-foot syndrome. In the context of trials, we typically will do 2 weeks on, 1 week off. And patients are on treatment for a while, and the hand-foot syndrome is not so much an issue over a few months, but if patients are on treatment, you know, in the US we tend to treat patients to progression so that patients can be on treatment beyond 6 months with 5-FU maintenance therapy.
And what about, and I guess at the 3-week regimen, if you're using oxali, the dose changes too?
Yeah, it's a higher dose, but patients do seem to tolerate it. You know, we start to see increasing risk of neuropathy. Typically, when patients get above 500-600 milligram per meter squared, you have to be very cognizant of that, and we usually will stop it.